The standard medical response to a low vitamin D blood test is a quantitative correction. Prescribe a high-dose oral supplement to increase serum levels. Yet in clinical practice, this protocol frequently fails. A significant proportion of patients supplement faithfully for months, only to discover that their functional status remains unchanged. The nutrient is entering the body, but it isn't producing the expected biological result. Contrast this with the strict carnivore diet. A daily intake of beef, chicken, and pork provides only 500 to 1,500 international units of vitamin D3, a dose conventional medicine considers too low to correct a deficiency. But clinical data shows a different outcome. While high-dose supplements yield stagnant trend lines, low-dose animal-based intake correlates with resolving deficiency symptoms. This happens because the standard protocol treats deficiency as a simple math problem, assuming oral intake is the only variable determining biological effect. In reality, a low blood test is often a symptom of a systems-level failure in the biological supply chain. The carnivore diet does not work by overriding the system with megadoses. It works by removing the physiological barriers that prevent the body from utilizing the vitamin D it already has. The first barrier is chemical. Circulating vitamin D is biologically inert and must undergo an activation cascade involving specific enzymatic cofactors. Magnesium is a requirement for this process. It acts as the necessary component for the enzymatic conversion of inactive vitamin D into its active hormonal form. Without magnesium to complete the reaction, vitamin D cannot pass this conversion point. Supplementation simply raises inactive blood levels. In plant-inclusive diets, magnesium is compromised by anti-nutrients like phytic acid and oxalates, which bind to magnesium. Animal products provide magnesium without these inhibitors, allowing it to proceed directly to the gateway, facilitating vitamin D's transition into its active state. Activation also requires metabolic coordination with two other animal-sourced nutrients, retinol, or active vitamin A, and vitamin K2 in the MK4 form. Retinol is required for the vitamin D receptor to bind effectively, while MK4 ensures that the calcium mobilized by vitamin D is deposited into bone tissue rather than the arterial walls. This synergy depends on active retinol. While plants provide beta-carotene, the human body must convert it into retinol, a process that is notoriously inefficient and often entirely insufficient for patients with specific genetic variants. By providing preformed cofactors, a meat-based diet supplies the exact biochemical matrix needed to transition vitamin D from a dormant state into clinical utility. Even when activated, vitamin D faces physical transport barriers, specifically the metabolic sequestration caused by obesity and hyperinsulinemia. Because vitamin D is fat-soluble, it's easily pulled from circulation. Expanding adipose tissue captures and traps the vitamin D molecules inside lipid droplets. These fat cells act as a reservoir that keeps vitamin D trapped, rendering it biologically unavailable to the immune system and other target tissues. This sequestration is driven by hyperinsulinemia. High circulating insulin inhibits the breakdown of fat, effectively maintaining the volume of these adipose stores and the nutrients trapped within them. This chart shows the effect of carbohydrate elimination. As fasting insulin drops, the metabolic signal to store fat is reversed. The adipose tissue releases its contents, and sequestered vitamin D returns to the bloodstream. Correcting insulin resistance does not just improve blood sugar, it physically mobilizes the body's existing nutrient reserves. By lowering insulin, the carnivore diet restores the systemic availability of vitamin D without requiring a single unit of additional oral intake. The third barrier occurs at the final destination, the cellular vitamin D receptor, or VDR. In VDR resistance, blood levels appear normal, but cellular receptors are downregulated by an influx of inflammatory cytokines. Triggered by high omega-6 seed oils, this chronic inflammation prevents the VDR from maintaining its structure on the cell surface. Removing these inflammatory oils allows the cellular environment to stabilize, supporting the re-expression of the receptors. However, inflammation is not the only cause of resistance. Research also points to the role of pathogenic immune evasion. Certain chronic intracellular pathogens, such as Epstein-Barr, have been shown to downregulate the VDR as a strategy to suppress the host's immune response. The shift into nutritional ketosis triggers autophagy. This cellular self-cleaning process rapidly breaks down damaged and foreign proteins hiding within the cell. By recycling dysfunctional components, autophagy may assist the body in clearing the pathogenic burden that is strategically suppressing receptor function. As the pathogenic load is addressed, the VDR can return to an active state. Resolving this resistance at the cellular level finally allows the circulating vitamin D to dock and initiate the genetic signaling required for health. The final barrier is located at the point of entry, the gut lining. Mucosal inflammation and bacterial overgrowth, like SIBO, can physically obstruct the pathways required for absorbing fat-soluble vitamins. Inflammation in the intestinal lining reduces the effective surface area for nutrient transport, disrupting absorption. The carnivore diet removes plant-based irritants, such as lectins and oxalates, that contribute to this inflammation. Simultaneously, animal protein provides high concentrations of glutamine and glycine. These amino acids act as structural building blocks, facilitating the rapid regeneration of intestinal cells and restoring the tight junctions. Restoring this barrier allows the gut's natural transport mechanisms to function, ensuring that even the modest amounts of vitamin D found in meat are absorbed with high efficiency. Viewed as a biological supply chain, it becomes clear that a failure at any single point, activation, transport, or receptor binding, results in a functional deficiency. We map the diet's impact across this diagnostic framework. It provides bioavailable magnesium and K2 for activation. It lowers insulin to release sequestered stores. It halts inflammation and promotes autophagy to restore receptor function. Finally, it provides amino acids to heal the intestinal lining. These combined mechanisms restore the body's baseline ability to process the nutrient. This has direct implications for clinical management. When a patient fails to respond to standard D3 supplementation, the solution is likely not a higher dose. Clinicians must stop viewing refractory deficiency as a mathematical deficit of intake. The diagnostic focus should shift to identifying which of the 4 barriers is obstructing the pathway: cofactor status, insulin levels, receptor resistance, or gut integrity. Effective clinical management requires moving past the bioavailability fallacy and ensuring the biological infrastructure is actually capable of utilizing what it consumes.